Hello and welcome to the EMSNation podcast. I am your host, Faizan Arshad. I am so excited to welcome you guys to an incredibly special series of podcasts. We have none other than the brand new podcasting crew from EMS World joining us at EMSNation headquarters on Candlewood Lake in the lovely state of Connecticut. So without further ado, I'd like my team to introduce themselves.
Sure.
Hillary Gates. I am the Senior Editorial and Program Director for EMS World, and I'm thrilled to be here with you guys today.
And I'm Josh Hartman. I'm the Vice President of the Public Safety Division at HMP and running the EMS World brand, and super excited. And thanks for the invitation.
And in the hot seat today, we have none other than EMS Medical Director Extraordinaire, Eagle, representative of the great state of Texas, none other than Dr. Craig Manifold. Welcome to the show, sir.
Always a pleasure, Faizan. And again, I wish I was in Candlewood Lake with you guys, but I will suffer through another beautiful sunny day in South Texas.
Try as you may.
Now, the topic of conversation today is something that there is a lot of banter about in regards to, is this an evidence-based practice? Can this procedure help our critically ill and or injured patients? And the question ultimately is, does it improve outcomes? But one of the flip sides to this conversation that we don't often consider in regards to procedures is, what are the inherent risks to the provider who is performing said procedure? And is the risk worth the benefit? So without further ado, the thing that we are discussing today is finger thoracostomies. Dr. Manifold, what's your quick take on it?
Well, this is a very interesting topic that's increasing its exposure, if you will, literally in the United States. It's been done in the pre-hospital environment in Europe, and there's been at least a few publications with retrospective components associated with them showing some success. And I think what we want to do is highlight today what are some of the differences in the processes that are out there and some of the controversies. And I'll be the first to say there is no question in my mind that can we share this procedure, instruct our pre-hospital providers in the U.S. on how to do this procedure. No question in mind whatsoever that they're quite capable to do it. But the real question becomes, is there benefit, as you mentioned, and should we really be doing this? And the jury really, in my mind, is still out. There's very preliminary information, and I think that's great to be able to pursue the science behind it, but it's certainly not ready for prime time at this point in time.
So let's just set the stage so that our entire audience knows exactly what we're talking about. You are dispatched as a paramedic to the scene of a multi-casualty incident. You are delegated by one of the on-scene commanders to approach a patient that appears to be the most injured. You arrive, are performing your primary survey, find the GCS to be depressed, are doing your primary survey. There's decreased breath sounds over the right anterior chest wall. In fact, you're able to notice some crepitus. The patient is in respiratory distress and has altered mental status. You know, we're all thinking, okay, this is a potential to save a life. You're concerned for a tension pneumothorax. How exactly, as a medical director, do you guide your paramedics to approach this in a practical fashion, a safe fashion, and an evidence-based fashion?
So my perspective is that this patient still requires a needle decompression in the setting of a tension pneumothorax. And I'm sure we'll cover some of the complexities of how to really make that diagnosis in the field. But I'm a believer in spite of all of the known complications with the needle decompression, what we really need to do is focus on doing it correctly and doing it well. And there are some ways that we can mitigate those particular issues. But I think, again, the focus of today's discussion is looking at needle thoracostomy or simple thoracostomy and how we can approach that. We have to be aggressive in patients with tension pneumothorax in the field. We can't afford to miss them. It is a time-sensitive, life-threatening process, and so we want our folks to be very competent and capable to be able to recognize and treat these and be comfortable in the field. There are obviously some limitations from state to state regarding scope of practice procedures that can be performed by our providers and things like that. So all those caveats come into play. Here in Texas, we're fortunate to have a delegated practice state with appropriate training and documentation. The providers are able to perform the procedures allowed by their medical director.
So I think that what you're saying is exactly right. We have an environment now where needle decompression is sort of the standard of care. And I think one of the big perspectives, and I'd love to hear what you think about it, is the number of times that it's done by a practicing full-time paramedic and sort of what they believe to be the signs and symptoms that give them the confidence that they can do the procedure and then do the procedure well.
Yeah, the needle decompression, I think, is well within the realm of the pre-hospital provider. In my personal opinion, the way that you do this is anything else. It has to become routine, right? It has to be part of your training. It has to be a procedure that you're able to maintain and sustain your skills. And so whether that is actually done on real patients and or a simulation lab, cadaver labs, and things like that, we have to have that continuing emphasis on it. Again, it may be a relatively rarely used procedure for folks in the field, but I think there are some ways that we can mitigate that as well. Personally, in my practices and our agencies that we work with, we encourage the use of needle decompression in cardiac arrest patients, particularly with PEA, to potentially address the tension pneumothorax issue. Now, I'll be quite frank with you, I don't expect a large number of those patients to have a positive effect, but I think what it also does is helps that individual medic be very comfortable when they do face that patient with a MVC, left-sided or driver entry. Patient has hemodynamic changes along with the signs and symptoms of tension pneumothorax. Because they've done the procedure so frequently or they're comfortable with it, it makes it a lot easier to perform that procedure in a patient who is awake and talking with them because they're familiar with the hand-eye coordination component of the procedure itself.
So let me play devil's advocate a little bit, Dr. Manifold. If we have this big needle that may not be reaching the space that we needed to in our well-nourished patients that we treat these days, shouldn't a finger thoracostomy do the trick? We're going in mid-axillary instead of mid-clavicular, and it's a simple procedure that maybe poses very little risk for a greater additional benefit. They're going to get a tube anyway when they get to the emergency department, so doing it in the field, what's the advice against it?
So I've got a few mantras to share with you here, and these are age-old conversations that people have. And I will tell you that just because we can do something doesn't mean we should. We need to make sure that we're doing it in the appropriate fashion. And the other particular mantra that comes up during this conversation that I have with medics quite frequently is with needle decompression, needle thoracostomy, what we really need to do is get the right equipment and perform the techniques correctly in order to do it. And so I am the first to agree that there are many complications potentially associated with needle thoracostomy, but I think what we need to do is really concentrating on doing that procedure correctly, and that will solve a number of our concerns or problems. As far as the space, again, whether it's an anterior approach or a lateral approach, I really don't have real hard feelings on that. I think either are quite appropriate. Again, the concerns are we getting the needle into the chest? And again, I think if we do that appropriately, we can use the anterior approach quite effectively. And it makes sense. Most of our trauma patients are supine, and that air would track to the anterior surface, if you will. And so I think that's where our better bang for the buck. And I know that's not perhaps what everybody feels out there in the field. They've adjusted to a lateral approach because of the complications associated with it. But again, I think if we're using an appropriate size needle and are familiar with the procedure, there are some things that we can do to really address that. So again, I will acknowledge that those discussions and arguments are out there. Call me old-fashioned, if you will, but I still think the anterior approach with a correctly sized needle, and we'll go over a few of those items, I think, I hope to make the argument that that's still a preferred process for us.
So when you're saying, so the anterior approach, which is certainly where I practice, is the preferred approach. But I think overall, wouldn't you agree that it's underutilized? that there are more patients out there in clinical practice, in whether it's arrests or otherwise to be identified tension pneumothoraces, that are not getting decompressed. And is that an education? Is that an experience, trepidation, combination? What do you think?
Yeah, so I think you're right. It is underutilized. And truly, I am an advocate for our providers knowing how to do this procedure and being able to perform it well. The ability to detect a tension pneumothorax in the field, I think, is complex. It's not nearly as easy as we would like it to be on the surface. One, a simple pneumothorax we don't need to address in the field, right? So this is a patient who has some type of hemodynamic compromise associated with it. These are the ones that we should be addressing in the field primarily. And I think that trying to diagnose that is very complex in our environment, right? We don't have the radiographic means to confirm that as we do in a hospital setting. So we're basing that on physical signs and symptoms that may not be as reliable as we would like. One of the areas that I think it is underappreciated is if there is subcutaneous emphysema. A patient or our providers don't get to see that as often as we'd like. And when it is present, that's a pretty good indicator, again, for pneumothorax. And we have to put it together with our hemodynamics to identify that. So I think it's not as simple as we would like it to be to identify and even confirm, and we have to be aware of that. Again, this is a fun discussion, and throw all of those caveats at me, and we'll try and address them as best we can.
We are definitely having a good time, and I think we're actually addressing, thoughts and concerns that real providers, boots on the ground, have, and these are the conversations that people have in their firehouses or while they're idle waiting for EMS calls, and rehearsing those high acuity, low occurrence incidents is what makes us better every single day. We have the unique challenge of needing to be prepared and having some expertise on literally everything that can possibly happen, whether that's disaster response or multi-trauma casualties. Now, in regards to the success of needle decompression, oftentimes we say you ought to hear a gush of air. And you can certainly imagine on the roadside or on the side of the highway that idea, well, I just did a needle decompression. I used the technique that I had classically been trained. Was I successful? How do you assess on whether your procedure or intervention actually made a difference? And then sort of the second part of that question is, don't I make that factor irrelevant by, instead of using a needle, actually using the finger thoracostomy technique, because I know I'm entering the pleural space, I'm able to decompress that air, and I have a tract in case I do need to further decompress or burp air if I am concerned that the pneumothorax is reaccumulating.
So that clinical indicator that is probably the best, I believe, is probably improved perfusion. And so again, we see the hemodynamics improve after completion of the procedure. It is number one in assessment pieces. I agree with you. Hearing the rush of air is probably not reliable. It's probably even unlikely in some of our pre-hospital environments that we're working in. And so I just don't think we can hang our hat on that. Dr. Arshad, as much as you are an evidence-based believer, and you just told me that you said, well, gosh, putting a finger in the chest wall should be able to confirm the proper procedure placement, if you will, and being able to look at that, I'd refer us to take a look at some of the literature that's out there currently. One of the papers that's gotten a lot of attention is from our friends in Montgomery County, Texas, over in the Houston area. Dr. Dixon is the lead author on that. And as well as Dr. Mark Escott, one of the previous medical directors who's now over in Austin, Travis County, or who are proponents of this, they and their service did a great job of being able to put this information together, collect the data as an EMS agency, looking at finger or simple thoracostomy in cardiac arrest patients. So I applaud them for looking at the data, putting a question out there and trying to answer it. What they reported is even doing the simple thoracostomy component, or finger thoracostomy component, that they had 2 incisions and finger placements that were extrapleural. In other words, their finger never made it through the pleural cavity to release any potential tension physiology. And then they also had a injury reported that went through the right diaphragm and into the liver, were reported during their retrospective case review. And so these are areas that are fraught with probably a little bit more what we might like to think about. I have a few other articles as we go along that we can pull up, looking at some of these procedures done, particularly in Europe, where there were complications associated with where they were primarily performed by physicians in the pre-hospital field. One study looking at actual simple thoracostomy, again, finger placement. It was not in cardiac arrest patients, but they identified major complications associated with the procedure of an empyema, scapular artery hemorrhage, 4 patients with non-relieved tension pneumothoraces. They considered a minor complication of lung contusions, which I think we can all live with. They also identified thoracostomies that were performed for a right main stem intubation. In other words, the provider got a little confused and didn't address that airway component first. And then even one they reported as a right thoracostomy that was performed for an isolated chest stab wound. And so I don't know necessarily if that was truly on the wrong side. There may have been some physiologic or physical exam findings that led them to perform that on the right. But again, this is not a procedure that is done without significant complications.
There's so much that we want to dig into there. I think there's a wealth of information and great evidence-based conversation to be had. Just for the sake of our audience, so we can make sure that we're all on the same page, Dr. Manifold, would you feel comfortable describing the procedure?
The procedure itself is, from a emergency medicine standpoint, is the initial component of placing a chest tube, a tube thoracostomy, but it's not with actual placement of the tube. So an incision is made, 1 to 2 inches in the anterior axillary line to mid axillary line in the fourth intercostal space, and then a finger sweep is performed where a finger is inserted into the chest cavity, the chest wall, to again release any potential tissue adhesions and perform and verify that you are in and accessing the actual thoracic cavity. So again, very easy to perform, a procedure that emergency physicians are quite competent and capable in. Again, we can teach and educate many, many people on performing this procedure. It's not a matter of not being able to perform the procedure. It's, again, looking at the indications in the environment and then the benefit that's associated with that.
I got to ask, from a paramedic's perspective, since we're talking about fingers, am I going to cut my finger, and is my finger long enough? So I think these are questions that people on the street are going to have for you, Dr. Manifold.
All right. So I was trying not to go where the size matter things, but I'm sure that your finger is, I'm sure that your finger is of adequate length to be able to penetrate.
But I'm a woman, so do I really care about the size?
This is gender agnostic.
Gotcha.
And it can be performed well by any of our genders that might be out there. So I think that is one of the real concerns associated with risk with this particular procedure. Now, Dr. Dixon and the Montgomery County folks, a relatively small sample size, I think it was only 50 or close to 60 patients. They did not report any injury to the providers that were performing this. And so good on them. Again, a crazy environment out there. But again, when we look at risk-benefit ratios, what are we really willing to accept? A needle stick, a knife injury, a scalpel injury, blood exposure, to even one of our providers is significant. It's great that you asked this. I just had a journal feed article this morning that came through that looked at emergency thoracotomy. Again, we're comparing apples to oranges, but this was performed in the emergency department by surgeons. And in their review of this article, they looked at 305 emergency department thoracotomies. 15 of those patients survived, 13 neurologically intact. So again, there is potential value to the procedure, but of their surgeons performing that, there were 22 exposures reported to that during that process. And so again, to me, a significant concern, worry that we are having our folks perform this, and is a real consideration that not only medical directors but agencies need to take into consideration if they're considering performing these procedures out there. So.
Yeah, and I think, when we were first doing that, when I was first doing these, we were using 14 gauge needles we quickly learned to what Hillary was alluding to before, and you discussed, was that may not be a long enough catheter to reach the space necessary. So we went to the thoracotomy kits, which did have a longer needle and was reaching the space, but it still had the form, and we held them, and we were comfortable with that particular piece of equipment. Other than the finger, we're entering into new ground in the pre-hospital space, putting a scalpel in someone's hand as well as Kelly's, right? These are new pieces of equipment. So whereas needle decompression now, 14 gauge needle or the thoracostomy kit, anterior space, we're looking right at it. We're darting, at a 90-degree angle in. We're pretty confident in that. But I think Hillary and I both feel like we want to expand, and we feel like pre-hospital care can expand. And so I'm interested to hear from you what you think the learning curve would be on, putting an incision, finding a different landmark, the mid-axillary fourth intercostal space, and then exploring, with your finger, which is not something invasive that paramedics are doing. So what do you think that would take to...
And if I could tag on to that, Dr. Manifold, also I imagine myself in the field of a trauma patient. Am I wanting to put this patient on my cot before I start? Do I do it right there on the ground and on the side of the road? Do I have enough space? Am I lying down next to the person? Do I sit on the bench seat? I mean, all of those types of things. We don't have that luxury of the ED.
And that's exactly right. And again, these factors all are considerations in performing this procedure for us. And you're talking to a military guy, so we're used to doing things in the dirt, on the ground, in the dark, in the middle of nowhere. And I think that, again, in some of those situations, that may be very appropriate to do it. But we have to assure that our folks are getting the appropriate training and familiarization with the process and are competent in being able to do it. And so you highlighted, Josh, a number of great ideas or thoughts that come into this. I will go back to the exposure component for just 1 second, if we could. And that is, and that goes along with this, when you're sticking fingers in the chest wall and the chest cavity, a lot of time we're doing this because of blunt and or penetrating trauma. And there's the potential for rib fractures that I've seen during my training and my experience over the years, and that you're putting that finger in, and we're all gentle and we're trying to be aware of that. But again, another risk that you have bone fragments and other things that are in there that you're going to catch on your finger. And again, potential body fluid, blood exposure that can be a significant concern for our providers. And then let's talk about personal protective equipment. How often do we see our providers wearing personal protective equipment in the pre-hospital environment?
Not very often.
Okay. Right. And so again, risk mitigation strategies, things that we have to be aware of and be able to do. And then we have in the dark, we're doing it again on the ground, in the side of the road, and we've got a scalpel laying in the field, all those sorts of things. Again, with appropriate training, we can mitigate some of those risks, but there are things that we have to think about. Dr. Escott described the training in his article, I believe it was in a publication a few years ago, the preliminary component to Dr. Dixon's study. And what they looked at was 4 hours of didactic training. Then they did a hands-on simulation and anesthetized swine model. So that means in order to follow that training schedule, you would have to have a what's called an IACUC or the equivalent of an IRB in order to perform procedures on the animals, not something you just go out there and do willy-nilly, obviously. And cadaver-based training is also available in a limited number of areas, although becoming improved. And I think that's probably a great model to be able to look at that. And that's one of the things we're fortunate to do with our agencies here in San Antonio with the Center for Emergency Health Sciences, is provide that cadaver piece. They went ongoing training twice a year in the lab to maintain their credentialing. And after all of that, it looks like they reported they had about 10% of their paramedics who completed that, or 30 paramedics with that. And then if we look at the volume of patients that they were reporting, again, over a 4-year period of doing this in cardiac arrest, they had 57 patients that were done. So let's call it 60 and 30 providers. And so over a 4-year period, if I do my math right, that's about 2 patients or 2 procedures per paramedic. And so one paramedic is performing this procedure maybe once, maybe twice a year if we look at the averages that come about that. For me, that's a significant consideration as a medical director, and in the time required to maintain proficiency in this is quite significant. Again, it's not that agencies aren't willing and don't want to put that effort into it. I think it is a real consideration and a factor that comes into play as to how much time and energy and resources are put into this. And so I think that should be one of the considerations at looking at doing a program like this. Now, as we get more EMS fellows and emergency physicians responding in the field, again, this is a procedure that is done routinely in the emergency department for most of those folks. They have the experience, the exposure with the equipment, and it's a matter of the change in environment and working with the team. And so there are still concerns and issues that are associated with the physicians performing it out there. But again, I think with appropriate training can be relatively easily overcome. I have no heartburn in particular with responding EMS fellows and physicians performing a procedure such as this in the field.
I don't know how your agency would respond to this, Josh, if you pitched it as a paramedic. Hey, can I stick my finger inside of somebody's chest and try to save their lives? But I feel like there, as Dr. Manifold said, there'd have to be a lot of buy-in. We certainly do some fun anatomy work with lungs from the butcher, but porcine anesthetized pigs is a little bit of a different story. So you'd have to be in a place where your agency, your operations, your chiefs would really buy into this.
Yeah, absolutely. I mean, all the way up and down the line, you'd have to have buy-in. It would have to be a complete buy-in because, like what I said before, it's regardless of what the end game is, which is the same, right? The end game is to release the tension, right? But because the approach is so different, the tools are so different, I think you're right. It would take buy-in, honestly, start at the state level, wherever you are, work your way through the system, depending on the state and the delegation of authority, et cetera. But it's called a simple thoracotomy, right? Thoracostomy, right? Simple, yeah. Right? So is it simple? I don't know.
Great question.
Doesn't sound so simple over here, although, it sounds like it could be a viable alternative if all these caveats are fulfilled.
I'll add, I think the procedure itself is simple, but again, like so many of the things we do, it requires the critical thinking of why we're doing it. Is there benefit to what we're doing? Because we haven't even talked about survival yet and things like that. So that's a part. But another area I wanted to go into, we talked about putting a finger in the chest wall, and I just can't let it slide. I found one publication that talked about some of the principles to consider, and it identified the tissues may reoppose during transport, so physiologic deterioration should prompt a refingering of the thoracostomy to establish the drainage tract, which makes perfect sense, but I'm a little hesitant if we're doing procedures that are requiring refingering. If we're doing something that requires refingering, it should probably be done either all the time or not at all. That's just my thoughts on the refingering components.
Right, and so why don't we put a tube in the field?
Yeah, I think it's for, again, some truly to keep it simple. Passing of the tube, again, everybody, if you're not familiar with the procedure, think, oh, you just slide a tube in, no problem. It's kind of like endotracheal intubation. Well, you just put that ET tube in between the cords, you're good to go. Getting the appropriate placement of the tube, following back in the posterior tract, making sure it's not in a fissure, making sure you're not driving it through the mediastinum, making sure you haven't injured any other vessels in the posterior blood wall, primarily making sure you even get it in the chest cavity, that it's not going in the subcutaneous tissue. All of those sorts of things add to a little bit to the complexity of that tube, especially in an environment where we have some limitations in confirming a replacement. In the hospital setting, again, we do a chest film and we're good to go. We don't have that capability out in the field, although ultrasound, we have one of the ultrasound gurus for POCUS with us. Certainly a consideration, but not well established at this point in time.
So, Dr. Manifold, you discussed the reaccumulation of air within the pleural cavity and recurrence of the tension physiology. As you know, one of the mantras of EMSNation is raising the bar all across this great country. And even things like high-performance CPR, we know there's so much variability, whether you're in Kings County, Washington, or you're in some other part of the state in regards to the performance. This day and age, we still have multiple agencies that are using, a 16 or an 18 gauge angiocath. What are your recommendations for best practice just to optimize our needle decompression itself?
All right. I am so glad that you brought that up. And what I'm going to ask people to do is bear with me as I talk about some generalities and then point you towards a new device that will, I think, be readily available. It's gotten FDA approval, if you will, and is waiting for some of the marketing components. I looked at North American Rescue as we were preparing for it. I didn't see it in their product catalog, but I know they're going to be carrying a decompression needle called a spear. And what that needle does is corrects or fix some of those problems. And as I mentioned earlier, my mantra is let's do the procedure and let's do it well. And with needle decompression, we know that there is the length of the needle, the circumference, if you will, or the size of the needle itself, how quickly the air comes out of the needle, and all those factors, kinking and all that stuff. So if we're able to overcome some of our limitations in our equipment and develop better equipment, we'll be able to perform this procedure better. And so the catheters that come out here in the future in order to address this, I think need to have some qualities that enhance that. And so we probably need to be using, for adult patients, a 10-gauge catheter, 5 centimeters in length or longer. Now, some of the new developments that we're seeing in these are actually adding fenestrations to the catheter itself. So the advantages of that are there's actually increased surface area and therefore increased opportunity for air to escape from the chest wall at a faster rate, with including those fenestrations as well as the larger size. So when we look at air escaping from the chest cavity with a 10 gauge with fenestrations, it will do it, the fenestrations add a 80% increase in the speed at which that will do. And then as compared to a 14 gauge, it's close to 300% faster that the air will escape from the chest wall cavity. Having a bi-beveled needle allows for a sharper, if you will, or better penetration through the skin and subcutaneous tissue, and then there are less tissue blockages associated with that, because that is one concern. You go through the soft tissue and you get a core of tissue and it doesn't allow release of that. So the combination of the bi-beveled needle and the fenestrations help with that. Having a catheter that is actually bendable. Most of the catheters, IV catheters you put in and you bend them, they kink off and there's absolutely no airflow and things like that. So the newer generation of catheters can bend to 90 degrees and still allow air to escape from those. Having a audible signal, a whistle and things like that can maybe another enhancement that helps in your confirmation of things, of correct placement. May not be the best for some tactical situations, but again, those type of innovations in the engineering, if you will raise the bar and enhance our ability to perform this procedure. And then in actually performing the procedure, really our common denominator, right, is just putting the needle in. And we talked about length. I can remember it's been a challenge getting even all of my agencies up until just a few years ago to switch from an 1.5 inch length catheter, because that's what they all had. So really we probably need a 5 centimeter catheter at a minimum. But the trick is it doesn't matter what the tissue size is externally to the chest wall. What we want to make sure is that we're getting the catheter inside of the pleural cavity. And so our actual measurement should be, once we put the catheter at the level or at the tip or the superior margin of the rib, once we get to the rib, from there we want to assure that we're introducing the catheter 3 centimeters from that point, not just from the external surface. So again, looking at how we perform these procedures and how we are able to utilize better equipment will enhance, and I think will really address some of those concerns that have been out there with needle decompression, needle thoracostomy. So.
One of the things I heard from a military medic way back was that we could attach a syringe with a little bit of saline in it and a little bit of air, and maybe it would bubble instead of air escape. You know anything about that?
Yeah, I think that's a very reasonable means of helping identify that there is air in the chest cavity, and you're, confirming that. I would add that on the other side of the spectrum, it's an additional step, additional equipment that you have to carry. Right. So again, what is that risk-benefit balance associated with that? And I think that's a true consideration. Absolutely. Can you tell that? Yes. is it worth the squeeze? And again, if I go back to a airway analogy, do I need to give a defasciculating dose of a medicine? I certainly can do that, but it's an extra step, and I'm not sure the true benefit in a lot of our patients.
So it sounds like to sum that up, it sounds like what you're saying is that education is important and bioengineering can help make the process of learning easier.
When I go to work on my car or do something out in the wood shop, I can get frustrated and work through all the processes, but when I have the proper equipment, it's amazing how much easier it makes my life. And the same in medicine. If we have the proper equipment and it's appropriate for the environment we're working in, it does a good job. And thanks to all of our partners in industry out there who really help us address these issues on a daily basis because of your innovation and your desire for feedback from the community. We get better equipment out there and things like that. So we're very appreciative of that.
I 100% agree, Dr. Manifold. And just because we don't typically recommend devices on the podcast itself, despite superior engineering, just wanted to make sure that you don't have any disclosures.
No, I don't have any disclosures or financial interest in the devices whatsoever. I guess the true disclosure I have is with our cadaver lab. We have done some of the testing for the device itself, but no financial interest from me.
Absolutely. I think the inventor is a mutual friend of ours, and we have tremendous respect for that team that continues to work on the logical and logistical approach to dealing with the pathophysiology.
Well, yeah, he should have put my name on the patent. Like that, so, yeah.
You have some anger disclosure.
No, I'm very proud of folks who participate in, again, the medics in the field who use their knowledge and find the weaknesses out there, if you will, of equipment and innovation to make it better for the next generation of folks to come along. It's really exciting.
Now, as we're wrapping up the conversation, Dr. Manifold, I wanted to discuss some of the potential differences between the state of Texas and the remainder of the country. I
thought they were their own country.
Yeah, that's an excellent point. That's an excellent point. So a delegated practice state, as opposed to some of our guidelines in regards to the national scope of practice, which I know certainly I listened to your lectures while studying for my EMS board exams. Finger thoracostomy in itself, as Josh was mentioning, is outside the national scope of practice in regards to guidelines for practitioners in other states.
In Texas, we were very fortunate, and I think it's very few other states that allow this delegated practice. But when I talk to colleagues, when we're sitting around at meetings, having a bourbon or two, I'm always re-energized and excited because we do have the privilege to be able to add at our discretion within a degree of reasonableness, if you will, that we can add these type of procedures and processes to our protocols with appropriate training and documentation and be able to potentially enhance the care provided to our patients. And so there's always the good with the bad. The positive side of that is that we are able to have a lot of flexibility. When I look at places that have state protocols, I will tell you I think there is an advantage there as well, in that their protocols are well vetted and have gone through a process that has multiple inputs and therefore is probably a better end product, but doesn't necessarily give you the flexibility that we have in Texas to be able to do that. So again, like with all things in life, there's good and bad associated with it. I'm very happy to be practicing as an EMS medical director in Texas, and it would be tough for me to go to other states where there would be some limitations on that. But we'll happy to adjust if needed. Thanks. So.
Fantastic. Well, that was definitely an incredibly well-rounded conversation regarding tension pneumothoraces in general, the limitations of the current state affairs of needle decompression, the description of the procedure of a finger thoracostomy, some of the evidence base that we have in regard to retrospective studies regarding this procedure. I remember attending a lecture by Dr. Escott, and he referred to his approach to traumatic cardiac arrest. I think this is when he was a medical director on the East Coast, as the 3-hole punch. And just discussing how can we as a nation improve our standards and actually perform interventions that improve our patient outcomes while limiting or mitigating the risk to the provider themselves. So even that nuanced discussion of PPE and scope of practice from regards of liability to the paramedic, etc., was riveting and I think educational for our folks listening.
One more piece of information I would be remiss if we don't share, and that's again in Dr. Dixon's study and the folks at Montgomery County. I wanted to highlight this as folks are really exciting and energized about performing this procedure. Although they did have some survivors, I want to look at point you to the results section. And they're comparing again in cardiac arrest doing the needle versus a simple thoracostomy. They identified and reported that there was no statistically significant difference with return of spontaneous circulation between the groups, and there was no statistically significant difference between those or for those discharged home after the return of spontaneous circulation and things. And so again, limitations of a retrospective study, but again, the procedure itself is not the be all and end all. We need to learn more about it. And I really appreciate the folks who have gone to this effort in the pre-hospital environment to enhance our research, get data analyzed, and go through the publication process and being able to share it with the rest of us. I know it's hard when we pick apart those studies, but it's information that's out there, and we can use that for the next steps as we build upon these particular procedures and life-saving interventions. And our goal is to, as always, to find the ways to help improve the care of our patients and keep our providers safe. So I really appreciate the opportunity to share a few words with you guys today, and look forward to the comments that come along with this.
Thank you so much, Dr. Manifold. You have the privilege, or rather we have the privilege of having you on as the very first recurrent guest on the EMSNation podcast. So thank you so much for your service and continued focus on the highest quality education for our providers out there.
Well, thank you. When we get done, I'm going to go celebrate then or something.
Where can folks reach out to you on Twitter or Facebook, et cetera, to connect with you and learn more about you?
Oh, great. Yeah, we'd love to have all the followers out there. It's at Dr. Craig Manifold, and Facebook is Dr. Craig Manifold, or you can reach out to me at manifold at uthscsa.edu via email, or we'll see you around at all the conferences, but love to talk to folks and love to hear your feedback. Thank you so much.
Lovely. And with that, I really, really, really would love to kick it to our special podcasting host today to tell us a lot more about the upcoming EMS World Conference in Nashville. I am so excited. For EMSNation audience members who have not booked your plane tickets yet, your hotel yet, what the heck are you guys waiting for? Hillary and Josh, tell us, what can we expect? Fill us in on the logistical details. What are the dates? What are your top recommendations, etc.? Drop knowledge on us, please.
You got it. It's Nashville, people. I mean, you got to be there. And guess what else it is? Halloween. So we've got tons of stuff planned. We have a 5-day conference, 2 days of pre-conference workshops that include anything from trauma to wellness, resiliency, yoga, MIH, POCUS, everything we love about this field. And then our 3-day main conference, Wednesday, Thursday, and Friday. The dates are October 29th through November 2nd, which is Monday to Friday there. And we've got Shot Fest planned. Zoll sponsors that on Wednesday night, which is a nice big party. We'll have a Halloween theme with the costume contest. We've got great speakers for the opening ceremonies. We've got speakers who are doing our general main conference sessions, who are talking about the Parkland shooting, who are talking about AI, who are talking about drone use in EMS, who are talking about survivability from ballistic wounds. And then we have tons of airway stuff. I think Dr. Arshad might be speaking on something about the limbic system, which I have to go to that because I'm not sure what he's talking about. And we'll have all of our partners there, NAEMT. We've got the meetings for a lot of the affiliates that are coming to the space. It should be the biggest EMS World Expo yet. We had close to 6,000 people attend last year in Las Vegas, which was terrific, and we're expecting the same this year.
Yeah, if not more. And I think that one of the things you'll find most amazing about our conference is the uniqueness of some of the things that we're doing. Some are, the cats are out of the bag already. Some will be promoting over the next few weeks, but certainly if you haven't booked already, please do so. We'd love to see you all in Nashville.
And with that, this is Dr. Craig Manifold, Hillary Gates, Joshua Hartman, and Faizan Arshad, wishing everyone a safe tour.